There are probably more red flags for airway than there are cavities in your office every single day, and you're missing it. But what if I told you that by the end of this, you will not only understand what exactly it is that you've been missing this whole time, mind blown emoji, but how you can utilize and leverage the information that I'm going to give you so that you can make more money, help more people, and just be all around more productive and fulfilled in your career. Yes, it is time for another one of our live lectures. I'm super excited to be here with you. Welcome, welcome, welcome. I'm Caries Laguerre. I'm your Mayo best friend, and I essentially am here with you almost every week to give you new information. So, don't miss out. I don't want you to miss out. Make sure that you subscribe. Make sure that if you are not already following the YouTube page, like follow, like turn on your notifications, make the comments, and like really participate. Because my goal is ultimately we get all of these like little areas of red tape, all of these barriers, all of these walls that people put up on their information and their knowledge in this field. We get all of that to come down and we collectively elevate ourselves to a point of excellence where we are all practicing at the highest standards possible. And we can't do that if the content doesn't go and grow. So share, share, share. All right. Let's hop on in because there's so much to learn and not enough time to do it. Now, we know as hygienists, and I am a licensed hygienist in 2 states. I don't practice clinically at all in any capacity, but I remember very fondly what it's like to be a clinical dental hygienist. So I've been in your shoes. I know what you're going through, and I know how everybody perceives us and what they think. And there's all of this noise on the internet about hiring a hygienist and do we need hygiene and can we have hygiene free models and we're divas and we're all of that, but we know that there's so much more to dental hygiene. But even beyond knowing that there's more to dental hygiene, I'm going to tell you that there's just more and more and more. There's so many ways that we can advance our career. Airway or no airway, whether you become a myofunctional therapist, like do something to elevate yourself in the career. You can become like you could become a sleep professional or a sleep coach. You can make sure that you're doing some other types of aesthetic work, and you can really help people in a dynamic way. That aside, dentistry has some similar struggles that we don't really acknowledge too often, but I think that dentists they get a bad rep, and it's not everybody. Just like all hygienists aren't good and perfect and pure and wonderful and amazing and wanting more out of their career, uh, not every dentist is the same, and not all of them are like cheap or not willing to grow and evolve and innovate and all sorts of stuff. So you have to really decide what it is that you want from your career. And then from there, let's take it a next step. Okay. When it comes to airway, I'm going to tell you that we already in clinical dentistry, no matter what you do in clinical dentistry, if you are in the back of the house, you are already working in airway. What does that mean? Well, you look at all sides of the airway all the time, whether you know it or not. Every single time you've looked at a maxilla, so you've looked at somebody's palate, I want you to know that the roof of the mouth is the floor of the nose. So when you are looking at someone's palate, if it looks narrow, if it's high and vaulted, you can only imagine what nasal volume is on the other side of that, right? If it's not too deep and it's broad, then you can imagine that floor, the nasal volume would be better, right? So you're already looking at the nasal pharynx. But what happens when you ask them to open? Because we're always asking them to open and we go intraorally, clinically. When you're asking them to open, you should have a visible look into their oropharynx. the upper respiratory tract through the mouth should be super visible. If it's not, if there's defensive tongue posture, if there's a super low or droopy soft palate, red flag, absolute red flag. You should be able to visualize the airway when you're looking in the mouth. If you've ever looked at someone's mandible, you've looked at the anterior and lateral borders of the upper respiratory tract. All back here, all back here is our airway. We're already looking at airway when we have things that are red flags just in dentistry: retruded mandible, soft palate, defensive tongue posture, vaulted palate. When we're looking at these things, you're already seeing the signs of the airway and that there are issues there. So I want you to start thinking of yourself already as an airway professional, because you are, okay? But outside of not realizing that airway is a thing for us, I think we also need to be very mindful that with AI, and my last lecture was AI, I asked ChatGPT, what's the issues going on with dentistry today? And it gave me a whole lot of things. And yes, we've got insurance and issues there, and we've got rising costs for dental practices. It is not cheap to run a dental practice. If you think that buying eggs is expensive, like, try buying gauze now and cotton rolls. As somebody who has their own private practice with tongue depressors and cotton rolls and that types of thing, I don't like these prices that I'm paying for that stuff either. So I can only imagine dental materials are also exorbitant in fees, the shortages, because there's just that lack of fulfillment. I could have only done, when I got into airway, like took a myofunctional therapy course, I took it thinking I'm never leaving clinical hygiene. I love hygiene. There's no reason for me to leave clinical hygiene. And then and then all sorts of passions started to kick in, and I did want more. And you never know when you do want more. And sometimes I think that's the biggest barrier holding some people back from committing to an office, is that some offices just don't offer anymore. There's this invisible ceiling that feels very visible when you come in, and every single day for decades after decades, you're just doing these repetitive processes of looking at teeth the same way, cleaning teeth the same way, using similar protocols. It might shift or change in how we want it to be called or named, or the terminology around it, but it's essentially the same. Like, we're doing repetitive tasks. And so the staffing challenges definitely is a big, big thing. Consumerism is on the rise. People want more. They want more that they can get out for their money, and out of less, right? So if I can go to my dentist and my dentist is able to help me with some of my traditional healthcare needs, that saves me a trip to my medical doctor. That saves me the ability to have to, go and find answers for things that might take me 4 or 5 additional visits, blood work, all this extra stuff at the hospital, urgent care, ER, an outpatient lab. Like, there are so many things that we have to consider in that manner too. And then, people just like themselves. And so there's a lot of cosmetic and desire for that type of stuff too. So when we kind of put together that our work area is already airway, and that there's a lot of issues in the field, I think you can maybe put together that if we think outside the box a bit, we can come up with a creative way to solve those problems and merge airway so that we are now looking at a resolution that helps everybody, helps patients, and helps us as practitioners. Okay. So we just got to think a little bit outside the box. And when I think about thinking outside the box, I think about the whole story behind Play-Doh. Did you know that Play-Doh really started out as a wall cleaner? It was Kutal, and it was to clean walls and wallpaper. And so instead of damaging your wallpaper, you could clean it. Instead of having to think about replacing it or tearing it down, you could clean it with this nice little sticky substance that wouldn't damage your wall and wouldn't damage your wallpaper. And you were able to get nice, clean walls out of it. Well, what's interesting is that there was a teacher who realized that like her kids like to play with this wall cleaner and wondered if there was a way to make it just a little bit more kid friendly. They added color, they kind of changed the name around a little bit, and it became something so much bigger. You don't know about Kutal wall cleaner. You have no idea about it. But everybody knows a household name, a household staple is the company name Play-Doh. That is a great way of thinking outside the box to solve a problem. The kids didn't have anything that was really crafty to play with. Traditional clay, if you've ever worked with like art clay, it's too hard. Like preschoolers aren't playing with that. But Play-Doh really took what was something basic and honestly never going to last the test of time. How many people are really like cleaning their wallpaper nowadays, at least with some type of like adhesive dough type material? Versus how many kids are being exposed to like sensory play and imagination and the creativity of Play-Doh. So we need to take what we can from examples like this, successful examples of innovation, to make sure that dentistry is able to last. Because dentistry, we've got a terrible reputation for not doing the things that we need to evolve. Now, we had a whole lecture last week, or my last lecture, I should say, that was uploaded for those of you watching the recording, was all about AI. But I'll tell you that AI is not new and it's not innovative enough for dentistry to keep people around. It might help keep some costs down, but if you're not increasing your revenue, what is the point of decreasing costs? You're really just making the problem that much smaller instead of widening the gap between your revenue and your expenses. Okay. So think about that, dentists who are watching. So we need to think about what else we can be doing. And yes, Airway is a way to integrate at an affordable rate something different, innovative, and special into the practice. And when I say special, it's that competitive advantage, that competitive edge. Not everybody's looking at all of these things, that picture of the little boy, the OMDs, oral myofunctional disorders. These are the things that are glaring red flags for everybody in Airway. And some offices are looking at it, but let's be honest, most offices aren't. And most offices now are DSOs, and they seem to be very disinterested in this as a totality. And so if you're going to be competitive, you're going to want to be the person talking about all of this, but you can't be the person talking about it if you don't know what it is you're missing. And so we're going to talk about how OMDs, oral myofunctional disorders, all contribute to some of these big signs that you are missing every single time you see somebody clinically. Okay. So let's start in with prosthodontics. And then we're going to go through each one of these and we're going to talk about what you're missing and what you could be looking for and how it all comes together. Okay. So prosthodontics and oral myofunctional disorders. Now, when we're talking about those, restorative work, a lot of restorative work has much of a clinical aspect to it. It's about your ability as a clinician, as a dentist, to be able to put these things in and to use materials that are going to make it last longer. But let's be honest, function and the daily use or forces that are put against your restorative work still play a strong role that we cannot ignore. The second we start to ignore it, that's when we create bigger problems. We get broken restorations. We get restorations that come off, that fall out. We do not want that. We want stability and retention for a lot of these things because people come back and they're angry. And you're like, well, it's your parafunctional habits. We can make you a mouth guard. Okay. Your big glaring red flag that you've missed all this time is anybody who experiences a parafunctional habit in their mouth. Now, parafunctional habits is a big thing, but most of what we think about when we're talking about that is bruxism. So we're talking about your clenchers, your grinders, okay? Mouth breathing is a parafunctional habit. Lip biting is a parafunctional habit. Cheek biting is a parafunctional habit, but some of that isn't going to damage your cosmetic and restorative procedures. However, because we know bone responds to loading, okay, and we know that because of the osteoblast osteoclast relationship and everything that we've been taught in dental and dental hygiene school, I know I just brought up some trauma for some of you, my apologies, but all of that loading against the bone, it creates additional damage, it creates additional wear. And if we're not mitigating that, we're going to see further deterioration of their restorative work. Okay. So we want to take a broader look at what's going on. And when we're thinking about implant cases and full mouth reconstruction or occlusal rehabilitation or bridge work or anything that has to do with the anteriors that's restorative or cosmetic in nature, you want myofunctional therapy involved. You want oral dysfunction to be resolved. And so that's going to be something where you're looking at reducing and eliminating those habits. You're going to be balancing the soft tissues. You're going to be establishing proper oral rest posture so that they are eliminating some of that compensatory action. That's the parafunction. We're trying to establish normal body rest postures and normal body soft tissue pressures. Okay. And we're going to establish proper jaw posture. And the jaw at rest should be ever so slightly apart. We need like a 2 to 3 millimeter freeway space in between the teeth. So they should be just hovering over each other. Otherwise, we're using the jaw to brace, and that's creating additional pressure on all of that hard work and restoration that you did. So ultimately, we're going to be able to help people if we're adapting Airway to have better outcomes for their prosthodontic work. Okay, that way we win, they win, and we feel a little bit more fulfilled because we've done just that much more. And I think if you think about it, if I'm going to spend $30,000 on implants and you're going to tell me, hey, your bruxism is really a problem, and I need you to spend $1,500, $2,000, whatever your myofunctional therapy fee would be for this type of case. I need you to spend XYZ on this because this is going to help your $30,000 investment go farther. Yeah, sign me up. What is $2,000 in myofunctional therapy if my $30,000 case is going to fail? Like, I would rather not be mad at you and come in really angry because my implant failed and I paid tens of thousands of dollars for that, right? Other restorative work that could be problematic and that oral myofunctional disorders do play a role in is dentures. Dentures. So we know bone responds to loading, yes, but we also know that our cranial facial structure responds to any sort of loss of structure, right? When there's a loss of structure, the cranial soft tissues, they start to cave inwards. We start to lose some of that bone that would be supporting. So all along the alveolar ridges, we're losing bone, and that's going to create an inherent alteration in the function, which leads to weakening. And that's going to be poor retention or a lack of our ability to really create a good seal or suction for some of our denture patients. And that is a big issue. We don't have to think of Airway as just being people with teeth who are crowded and open bites and tongue ties and all the things that people really think Airway means or dental sleep medicine means. No, we can deal with the soft tissue pressures in the dental practice to help to address some of these things that are very common. Every practice has something to do with a denture. Dentures are something you learn commonly in dental school. We understand what we're supposed to do with these types of cases. Like, you don't have to do a residency or go get your diplomat as a dental sleep medicine person to do airway. You could just be more focused on how dysfunction in your work area is impacting your patients. And that's incredibly important. So myo with dentures becomes really, really important because you're going to be able to evaluate and remediate any sort of compensations, asymmetries, overdevelopment, underdevelopment, improper oral rest posture that can contribute to a quickening in that loss of bone and stability, a degradation of the function that the patients have, and therefore improve your denture stability and comfort, reducing some of those sore spots and increasing patient satisfaction. So if I have dentures that are fully covered and I tell my patient, oh my gosh, your dentures, I'm so thrilled to tell you it's fully covered. Your dental insurance will be taking care of that cost. All we have now to discuss is how you're going to maintain this long term so that you're not in here paying for it because the insurance will pay once. But what we've seen happen before is that we have a loss of function or a change that leads to discomfort and sore spots and your inability to wear this over a period of time that will be covered within our coverage window for replacement. So what I'd like to discuss with you is your oral function and a myofunctional therapy program that would be abbreviated, but that could be something that you talk to our hygienist about, you talk to our dentist about, you talk to them about, so that we can create these better outcomes for you. That's such a great offer. It's an amazing offer. And if you start talking to me about the other benefits that go along with it, like the real airway stuff, so the sleep stuff, the snoring stuff, the open mouth posture, the dry mouth, if you're talking to me about that stuff, the indigestion, the heart concerns, if I have diabetes and you're telling me all the connections, what? Of course, I want myofunctional therapy in my life. Why would I not? It's going to help with my dentures and overall wellness, systemic health. Sign me up. I'm willing to pay out of pocket. Stop trying to charge insurance. Like, take my money, please. Okay. Maxillofacial surgery. Oral maxillofacial surgery is something that I think a lot of us are talking about now in different ways, right? So when we think about our oral surgeons, we think about extractions or complex extractions, and we think about biopsies, cancers, and that types of thing. But if we're thinking about it from the airway perspective, there's a lot of people who have malocclusion that can only be resolved with surgical outcomes. So how did we even get there? How did we get to craniofacial development that was suboptimal to the point that now you need surgery to come in, break your bones, and then put them in a new position? How did we get here? It's all about the oral rest posture. You have to really understand your craniofacial growth and your cranial morphology. Like, you have to understand why we got here. And once you get that, there's a whole other lecture about etiology. I will link it at the end of this. But you have to understand how we got here in order to get to, well, this is how we get back. And I heard something very interesting. So I have a oral surgery case that I'm following for I'm following it for a number of reasons. One, because she's my client, but two, for one of the Myo launch courses, where we really do dive into specialty care. But Myo recovery, where we talk about oral surgery and we talk about how you can work your way through a case and prep into a surgery and prep for functional outcomes after, it's really important that we understand and know our roles. I don't try to over talk surgery and what it is I know about surgery and what's going to happen on that table, because structure, that's not me. I deal with function, and I like to stay in that lane and stay in that zone and stay in my window of excellence. So it's very interesting to me where yesterday I was working with a client of mine who is prepping for, this is a particular case specifically that we're following for this course, but we're prepping for surgery, which is next month. And in our pre-surgical visit, she's like, well, my oral surgeon said that everything just kind of resolves itself. Like once the tongue has the space, it knows what to do. Well, that's really interesting. I've never heard of that before. And I've worked with lots of people who haven't needed oral surgery, but still need functional remediation. How funny that they have space and the tongue just doesn't know what to do. That's in no way, shape, or form accurate. It just doesn't logically make sense that you could have muscular dysfunction and then magically you wake up from a surgery surrounded in inflammation, you're on pain medication, you're probably on some types of relaxers and muscle relaxers in some instances, but your muscles are going to know exactly what to do. You're going to function completely differently. No, that's ridiculous. It's absolutely ridiculous. Altering structure doesn't inherently change the function unless you want a negative. So, unless you're looking for a compensation, like if you come along and you break my foot, okay, well, if I still want to walk around on my broken foot, I'm going to have to figure it out. So I might hobble, I might compensate, I might start hopping, but I'm not going to just magically manipulate my body so that I'm now walking better because something was broken or something changed. It's going to be a negative, like recruitment or something compensatory. So I think that it's incredibly important that we're all aware that structure and altering structure does not inherently change the function. So you have to work together when it's myofunctional therapy. And let's say you have an oral surgeon in your practice, or you guys are very forward and you do these things in your office. Well, then, yay, myofunctional therapy is a great thing to add for pre surgical prep, post-surgical recovery, and improving function post-operatively. That way, you're less likely to relapse and you create more stability in the new manner of which they are positioned. Okay. Yay. Aesthetics, beauty. There is nothing more exciting than being in the beauty field. And I think a lot of people think Botox, facials, creams, and all sorts of things. But beauty is actually just muscle deep. A lot of it is musculature. And if you work on your musculature, you can naturally improve your facial aesthetics. Think of face yoga. Face yoga is just like, the poor man's Mayo. It's just something that you could do to help keep yourself looking more lively. And so it's important that if you're seeing patients that have any sort of dysfunction, asymmetry is in their face, they smile, and you're like, oh, the smile is crooked, or you see one side of the face looks more prominent than the other. Well, then you know that you need to get in there with some myofunctional therapy because you can balance all of that out. You'd be helping to eliminate the asymmetries by strengthening the sides that are deficient. And you'd be surprised to know that oftentimes it's not the side that's more prominent, that's the deficient one. It would be the exact opposite. And so it's important that you're able to assess and to look at people and to be able to offer solutions for those types of things, because we always talk about people's smiles. We always in dentistry talk about how a smile, we love being able to change people's smiles and allowing them and enabling them to smile. Do you know how much more confidently you could smile if your face looks younger, if your face looks more even, if you're more symmetric and it didn't require Botox, which is temporary at best, to produce those types of outcomes and results? You really could make a world of difference. So aesthetic changes that you want if you're trying to combat the need for other types of cosmetic and restorative procedures, Absolutely. Myofunctional therapy is a great thing to do. There's actually a whole course in the Myo Launch Library about it. Myoaesthetics, where there's actually a library of like 40 exercises, like how you can actually change facial aesthetics. It is an entire, like almost specialty of itself within myofunctional therapy. So it's something that you could utilize if you have like a dental spa and that's something that you do, you work on the aesthetics. You've been missing it all this time. These people who come in and who are aesthetically asymmetric, that's a great opportunity for you to do something new, different, and impactful. Let's talk about TMD because everybody's talking about it in every office everywhere, and they're probably just calling it TMJ. And that's a little bit of a pet peeve of mine. They're like, oh, I have TMJ. Like, oh, yeah, I have those too. It's your temporomandibular joint. Like, what's the problem? We all have one. Um, but TMD, like the dysfunction or disorder of the joint, we know muscles over absolutely everything. Okay. So the muscles of mastication are going to aid in the joint's function and be really pivotal in 70% of any sort of dysfunction in that joint, clicking, popping, all sorts of things, displacement, and how we would revise and remediate that. 70% of that is muscular. So you want to be able to address that in a positive way. And so you're going to remediate dysfunction that can contribute to additional wear and, ultimately degradation of the joint itself. I will say that a lot of people don't talk about it very often, but the swallow is really important. People who have a tongue thrust swallow or the tongue pushes forward for the swallow, that creates a backward force on the mandible, which then creates an additional upward force of pressure along the joint itself. And then that continues to contribute to wear to the disc, and this displacement often can occur like when there's just too much wear and everything just kind of slides off. So myofunctional therapy is really, really good. Every patient with TMJ, you've been missing an airway opportunity every single time. It's just not something that I think we need to dive too deep into, but remediation of functional compensations and recruitments absolutely going to help you to eliminate or reduce some of those oral parafunctional habits, and ultimately just establish a new pseudodisc. So any clicking, popping, we can get that to stop and create a better pathway for functional stability and mobility of that joint. And last but not least, my absolute favorite thing to talk about, oral myofunctional disorders and periodontal disease, because why is nobody talking about this connection? Periodontal disease is something that we're seeing and people are documenting within the DSO world, within American dental practices, as having like an 80 and sometimes over 80% prevalence. So a lot of these offices, they're saying most of your patients have periodontal disease. Well, what are you doing about it? Are we just doing SRPs where there's been a lot of research that we can't get deep enough that we're actually cleaning it out really well? So when there's over a 7 millimeter pocket, like what are we doing? Most times research has shown absolutely nothing to help, right? You could do periodontal surgeries and, get a flap surgery in and go and get everything out. But how invasive do we want to be for periodontal disease? And why are we only addressing the biochemical causes of it? Why are we not addressing the fact that there's a biomechanical force that does, remember, bone response to loading, create an impact? So when we have parafunctional habits and like high occlusal forces, or we rest with our jaw together, clenched, and we create that additional force, or we brux and grind and we're doing all of these things that are creating additional damage with excessive vertical forces, it creates vertical bony defects. And that is now going to contribute, along with inflammation along the gingiva, is going to create a wonderful opportunity for opportunistic anaerobic bacteria. Now we got the biochemistry to sit in those spaces. So we have a lot of people who come into the practices and are like, I've been brushing, I've been flossing, I've bought all the things, like I'm doing what you want me to do. And why is it that this periodontal disease doesn't go away? That I have to come back, or that I've had 2 or 3 deep cleanings in my life? Like I'm doing what I'm supposed to do. It's because we've all been ignoring, like we can't see it, the biomechanical forces, parafunctional habits, and the impact that that has on periodontal stability, or instability, I should say, and enhancing the instability, preventing you from achieving true stability. And so we need to stop ignoring that. It's incredibly important. There's nothing more important than creating that stability. And if we're going to do so, we probably need some myofunctional therapy, some oral dysfunction remediation. Okay. That way we can balance soft tissue pressures. That way we can establish proper rest posture and eliminate any sort of jaw compensation. And we're just going to be able to provide our patients with an additional way to now create a harmony intraorally that they've been seeking for so long, and that no other office has been able to offer them, because you can go anywhere for a deep cleaning, absolutely anywhere. But you can only go to about 1% of places that are going to talk to you and give you the real about how your dysfunction is contributing to your periodontal disease, and we have something you can do about it. Got to think outside the box. Got to think outside the box. So when you look at those things and you think, oh my gosh, I've been missing all these things, or I didn't even know that that was Airway. Like, how was I supposed to know that restorative cases or denture people need Airway? What? They need Myo? That's wild. That's okay. You learned something new. So now what are you waiting for? What are you waiting for? Why are you here watching this? You should be going and telling the whole world about it. I'm joking. No, but you should be able to, at the very least, start having the conversations with your patients. Start informing them that you've learned some new things and that you are ready to help them. And or if you're not ready to help them, or you don't know when you'll be ready to help them, that you've seen some things, but we're just going to wait and see. We're going to wait it out. We're going to see if this gets worse. And while we're waiting it out, because you know you're going to see them, we all have different recall schedules. Like you're getting them back into your chair every 3, 4, 6, however many months or weeks. You know they're coming back. So that wait and see doesn't have to be years from now. It's wait and see in a couple months, and then we'll work together. But to start the conversation for real, you just need to understand the opportunities that you have to have these conversations. Okay. So while you're taking their medical history, or while you're reviewing it, you want to look for some of the red flags and signs. There's an entire lecture about it. I will also link that at the end. But high blood pressure, diabetes, any digestive issues or disorders, definitely any sleep disorders, anxiety, depression, like all of those things. You want to know and start having the conversation that this might be linked to oral dysfunction that we can do something about. Extraoral examination, or even the intraoral examination, when you're looking and you're watching their airway and you're seeing these things, you need to be mindful that that is a great opportunity to start mentioning that you're seeing things. I see your scalloped tongue. I see the hollowing of the space underneath your eyes. I'm seeing these things, and I just want to put you on notice that there are things we're starting to look at a practice to help provide enhanced care, because there's so much you can do here that will cross over interdisciplinarily, and that your primary care physician would be happy to see the results of. Like there are things we can do here to address not only these things I'm seeing dentally, but what you're experiencing, how you're feeling. Okay. And then exploratorily, like if you're asking them different questions about how they're feeling or about their sleep, like there's wonderful opportunities for you to start those conversations. But essentially, I think you really just need to be aware that you're being presented with a choice here. You have the opportunity to evolve, or to just keep ignoring it. You could hear no evil, see no evil, speak no evil. Okay. But I really would love it if you would just take the next step to just learn a little more. There's 70 hours of education here on this YouTube channel that you can dive into to help you thrive and get to the next level in your career and in your impact. And all of this will absolutely be able to up level your revenue and the practice revenue. There's a lot of hygienists that are making an additional $25,000 a year, if not more, by adding in myofunctional therapy into the practice. And, you can break that down into percentages and monthly, how much you're bringing home and all of these things. But practice owners, you're able to add almost $250,000 to your annual revenue. Just having one practice, one hygienist, start implementing myofunctional therapy for all these different types of cases. It doesn't all have to be airway. If you're not doing expansion and appliances and all that kind of stuff, you can still do myo. It is still impactful in so many different ways. So if you're willing to evolve, learn more, take the next step. There are so many things you can do, but if you're a hygienist, I want you to make sure that you're looking into the Airway Hygienist Academy or the International Association of Airway Hygienists. There's going to be a fabulous fellowship program that's opening up in 2026. I'm super excited about that, but you could become a myofunctional therapist. You could become an airway hygienist, dentist, or DSOs. Myomerge.com. You can absolutely integrate this into your practice. It is a low cost investment. If you're like, I've never wanted to do tongue ties or airway because all these things, it's like 5, 20, 50, 70, $100,000 programs. Myofunctional therapy, less than $5,000 most times, less than $5,000. It's a low cost way to really add to the bottom line. So follow, like, subscribe, watch the next video. It's going to pop up in the corner, but make sure that you are absolutely doing more, because the more you know, the more you grow, the better we can all be. I look forward to seeing you at the next one. Bye, Myo best friends.